Got it.
Welcome, everyone. Hi, everyone that's popping in. I know some of you all are trying to get your sound to connect, and that's fine. We would love to see anyone who's willing to show their shining face at 4:30 in the afternoon. Not mandatory, but we love to see it. It makes us feel like we're not just talking to our computers. It is right at 4:30. I'm going to continue to let folks in, and I've already started recording, but welcome again. I'm Melinda. I am Director of Advocacy for the ARC of North Carolina, and welcome to, I believe this is number 8 of our Medicaid transformation series, in which we are trying to provide information to you guys, whether you're staff or your families or parents or self-advocates, and answer questions that you may have, even if those questions seem elementary or like you should already know the answer. Somebody else in this group probably has the same question. So with that, I'm going to turn it over to John Nash and Lisa Petit, and we're going to get started. But thanks for joining us today.
All right. Well, I'll start off just couple quick things to be aware of. Again, to repeat what Melinda said, these are great opportunities to ask questions. A lot of times people are nervous about asking because they don't want to feel foolish. Nobody should feel foolish in this crowd. There should not be any question that's off the table. We will, from time to time, because we live in the middle of this, it's hard not to allow acronyms and terminology to slip into our conversation because we are in the middle of this pretty much all day, every day. And we will do our very best to keep it as plain language and straightforward as we can manage. But I will not guarantee that we won't, from time to time and probably frequently, slide into language that is a little bit more technical or in the weeds or hard to understand. Please call us on it. With all respect to everyone on the call and anybody that's listening in, or we'll be recording this so that people can download it later on. We want this to be plain language, and you use the terminology that we deal with on a daily basis so often it's hard not to let it slide in. So if it does, we will not be offended. I guarantee Lisa and I will not be bothered if somebody says, and what is that acronym? Or, you used an acronym, anything to signal us. And for staff on the call, if you catch us doing it, please note it and let us know so that we can correct that, or at least ways add to that, whatever that acronym is. And if hopefully as we go by, people will begin to be a little bit more conversant in some of the acronyms, get thrown out there, at least ways to be able to be aware of what it is and what it stands for. And I'll be honest, there are some of the acronyms I can never remember what they stand for. I just know what they're supposed to do. So, there we go. Other than that, just to make you aware, questions that you ask us, we will answer whatever we can. We will likely have questions that we don't have answers to. We've always done that. Whatever you're asking, we'll share what we know, and what we don't know, we're taking back to the department, and we are having regular conversations. Had a conversation last night with senior leadership from the Department of Health and Human Services to talk to them about the kinds of things. And some of those folks may actually be on this call. We invite them. They need to hear what we have to say. And this is the best place to hear from the actual people who are in the middle of dealing with this whole transformation thing that we're going through. So the invitation is ask questions. Don't be uncomfortable asking what you think may be a foolish or a stupid question. You hear that often enough, but believe me, if you have the question, I guarantee there's at least half a dozen other people on this call that will have a similar, if not the exact same question. So that is the basic ground rules. We only ask that you be respectful because we're trying to navigate this along with everyone else, but we will be here as best we can to make sure that there is somebody out there that you all can turn to that has answers for you to the degree that they're available. That's what I have to start with. Lisa, did you want to add anything else?
No, I'll echo that and second it. And if you catch us using acronyms, just stop us. It's just simple.
throw up, but raise a hand, do something so that we know that we slipped.
Yep.
So that said, I think to start, I don't remember where we were the last time we met, but transformation, the go live date has been pushed back for the tailored plans. And I want to make sure that's clear. The tailored plans are the funding agencies. They are it's the same ones that we've had via Trillium, Sandhills, Alliance, Partners, and East Point, the 6. They are currently funding agencies only. Beginning on October 1st of this year, they will become insurance companies, which on our end of it looks pretty close to the same. And they're writing checks and paying the bills for things that we need and that we rely on, and that's fine. But on the inside, how it operates and how it's regulated and how it's put together, an insurance company is a very different thing than a funding agency. Tailored care management is the activity that these tailored plans do. Tailored care management began in December of last year. So we're providing that service that was put together as part of this. That's been going on since December, but it's taking time to get everybody onboarded. The agencies that manage this, the insurance companies, that they're called tailored plans. You'll hear that term TP flowing out there. It's not paper, it is tailored plans. The tailored plans will go live in October 1st, and that has some issues with how that's managed and how it's done. They have to get together between now and October 1st. They have to get together the doctor panels and the medical providers that are necessary for what we do. That's what they have between now and October 1st to pull together. So that's at a quick summary of where we stand today. So we are providing tailored care management. That's the activity. The tailored plan is the insurance company that all of our LME MCOs, Alliance, via Trillium, Partners, East Point, Sandhills, they're all becoming those insurance companies. And at some point, you'll either have somebody from one of those 6 or an external organization like the ARC and several others. There's a number of us that are doing tailored care management that will help connect you with whatever services you need, be it a doctor, day services, employment services, housing. It covers just everything that involves our community in the IDD world. So that's where we are today. How many people have questions about that?
Todd has a great question. Todd, did you want to say something? You're on mute. Or I'll just
Sorry,
read your question.
I just put one up because,
Yeah.
I mean, I know we have to be very careful on advising because I'm not versed in all that, but VIA is having issues getting our medical providers, the ones that our clients are comfortable with, under contract. I mean, so I just wonder what y'all's advice is on when they ask me or their QP or whoever, you know.
We've done a couple of things in the past, Todd, and we continue to press the state on how's it going with the doctors? How's it going with the doctors? Are the doctors signing up? We get a vague answer that it's in progress. But we hear from you all and from people on the ground that the doctors are not necessarily signing up and have said they're not going to sign up. So we know that's happening. There is a letter on our website that we wrote with another group that parents could or family members could use to take to their doctor that basically says, we'd like to keep you, please sign up with VIA or whatever the LME becoming tailored plan would be. I think the the most important thing we need to do is tell the truth, be honest with families, and say, you may lose your doctor in this process. You might. And you should be looking at backup options in case you need them. You might want to talk to your legislator about this issue. You might want to talk to your county commissioners about this issue. You may need to do some advocacy, and it may not help. So I think we got to be honest with folks that there are going to be some people who lose doctors, and who lose those very important long-term relationships with people who understand them, medical staff who understand them. That is going to happen in this process. Now, as we say that, keep in mind, they've pushed the launch date back to October 1st. That gives us a little more time. And then right now they're saying they will continue to pay doctors out of network as if they were in network for 6 months after October 1st. That gets you to the end of March 2024, right? So we're about a year out before people would actually have to switch doctors, but that'll come fast. So I think we do have to prepare people that some folks will lose doctors.
Thank you. Thank you so much.
And we all have to keep pushing. We're pushing at the state level, saying to the state, you need to find a way to make this work. Having 6 LMEs is an issue for doctors, especially since they've already signed up with all the standard plan providers. And you're messing with the people who have the most intense needs in the state. This is not a good thing to do. This doesn't quite make sense. So state of North Carolina, you guys figure out how to get doctors in and out of this system easily, how to get them in this system easily so they can get their claims paid easily. Each of the 6 LMEs will have different claims systems. So if I were a doctor and signed up for all 6 LMEs, I've got to have staff who can manage 6 different systems to get me paid. That shouldn't be happening. That's not realistic. And small practices can't afford to do things like that. So we're pushing the state on figuring it out. Some of it is tangled up in Medicaid rules, Centers for Medicaid and Medicare Services, and the waivers that have been approved for the state, meaning the 1115 waiver, which is the waiver that's creating the new managed care system in this state. There are lots of rules around that. And in some ways, their hands are tied, but they got to get creative. We just keep saying, you got to get creative. You got to figure this out. Be innovative.
The conversation that I had with the Department of Health and Human Services yesterday, and again, what we are doing with tailored care management, this whole process doesn't just work on people with intellectual and developmental disabilities. It includes people with traumatic brain injuries, with severe and persistent mental illness, and substance use issues. So this is a big group of people. That said, for the population, for our community of people with intellectual and developmental disabilities, and for the group of people that have traumatic brain injuries, because they kind of fall into this same category, the group doctors that they have so far succeeded in signing up works very well for the severe and persistent mental illness and substance use groups, because they have a different medical need than we do. In our case, we have a lot of specialists, a lot of very carefully cultivated doctors and medical providers that know who we are. We've spent years building up those relationships and making sure they know how to deal with us. The conversation we had yesterday reminded the department of that, and they acknowledge they agree with that and see that, and kind of wondering, what do we need to do to fix that? And we've offered and will continue to offer to be a mediator to help bring them in. This is really something that the Taylor plans have to do via Trillium, Sandhills, Partners, the 6. They've got to go solve that problem themselves, and there's some issues there. We're giving this probably another 4 to 6 weeks. We're watching carefully. If we don't see significant movement, then we may look at taking alternative measures to see what we can do to help move this along. We don't know yet. We're working on those details, but we're definitely sensitive to the needs of our community. We can't do without our doctors. I think I saw a question, what happens if we have to choose? Well, how can we choose? You need the day services and the long-term services and supports, in some cases, just to get out of bed and get going in the morning, to provide that daily support that you got to have. You can't turn that off, and you can't turn your doctors off, which puts us in a really uncomfortable place. So
Yeah.
we are very, very, very intensely aware of that issue, and so we're going to do what we can, and the more we hear from you, that we may ask for folks in this call and others in our community to make phone calls and to reach out and say, hey, we think we might come up with a solution, but we want to wait and see how things settle in first. Let's let it take its natural course for the next few weeks. We've got till basically a year from now before anybody really has to panic, so we've got a little bit of time. That said, that clock ticks pretty fast. So we're giving into the next month or two and see where it leads to, and then we might have some other options that we might throw out there. We'll see. But until then, stay the course and keep asking, keep pressing. Your doctors, speak to your care coordinators at the LME MCOs that you're working with. Let them know that we need our doctors. And ask them, what are you doing to get my doctors lined up?
So John, there are a couple questions in the chat, and I'll just read them out so that we don't miss them. And you guys are great. Keep putting them in there, and we'll try to get to as many as we can. So Mike asks, how does the tailored plan compare to the non-tailored plan in terms of keeping the same physician who has had someone for a decade? Is there any info on the UNC healthcare systems in terms of whether they're signing up?
I can say UNC has signed on with Alliance and said that they felt they needed to sign on with Alliance since it's in their region before they signed on with others. So we would expect they'd now be starting to sign on with others, but UNC has started signing up and contracting. As for the difference between tailored plan and non-tailored plan, for folks in the standard plans, which is the non-tailored plan, there are a lot more doctors there. The general Medicaid population is much, much larger than I think it's around 300,000 people who will be in the tailored plan. That's a small group of people who have more intense needs. So if you think about the much larger Medicaid population in the state, most of those folks are in the standard plan, and those standard plans are run by major insurance corporations, right? So Blue Cross Blue Shield runs Healthy Blue. We have WellCare. We have Carolina Complete is the only locally run one. There are 5 total in the state. Those companies are used to working with doctors. They are used to having doctors on board. Doctors are more ready to sign up with them. They are the insurance companies who know how to do this business. And so they're flush with doctors. For some folks with IDD, we have heard conversations about, do I leave the tailored plan and lose my services and move to the standard plan so I can have the doctor that I know and have worked with for many years, because most of those doctors are signed up with standard plan providers. We don't think that's fair choice. We don't think people ought to have to even be having those thoughts, much less make those kinds of decisions. Somehow, again, the state has to figure out how to get those doctors signed up with the tailored plans as well. Mike, I hope that answers your question.
Thumbs up from Mike. Kathy says, so I have primary insurance with Medicaid as secondary. I choose a PCP based on my private primary insurance. Can I still keep my PCP based on primary care and not choose one in the tailored plan?
That's a great question. I don't know. you should be able to continue to see your primary care physician and have your primary insurance pay that physician. And in my opinion, Medicaid shouldn't care because they're not paying, right? They may force you. I don't know if they would force you to choose. I doubt they would force you to choose one. They would just assume you have one who's out of network and you're paying it a different way. I think that's how that would work.
By the way, in this case, PCP is primary care physician. Just trying to stay on top of our acronyms.
Thanks, John. Well, one thing you'll know about the ARC, if we don't know, we will tell you we do not know. And we do not know a lot of these answers, but we are going to do our best. Marjorie, hi, Marjorie. She says, can you please review what are the new services under 1915I offered under the tailored plan as compared to B3 services?
Well, there aren't any new services, Marjorie. What they're doing is really kind of crosswalking the current services to the I option services. And the I services are going to have kind of larger service definitions with more flexibility there so they can move more over into those services. So you'll see supported employment and respite. And I think there's one called, it's similar to community living and support, but I'm blanking on the name right now. But they are designing that to incorporate all of the current B3 services under different or similar names. So really no new services.
The big difference between the I option versus B3, the B3 dollars is what was left over when the LME-MCOs were spending Medicaid dollars before. That was the excess that they used to add additional types of services, things that they could do in addition to. So it was used, they were supposed to use their savings that way. The I option, on the other hand, is a Medicaid item. So it in effect, where B3, when the money's gone, the money's gone. With the I option, it's an entitlement, which means once you're signed up, if you've got an I option, that runs in perpetuity until you accept, a waiver slot comes open and you accept a waiver slot, then you would move out of the I option and into an innovations waiver slot. So it's a big difference in terms of the availability, because under B3, there is a limited number of people that can accept B3 services. My understanding is under the I option, I heard Kenneth Bossell, who is one of the folks from the Department of Health and Human Services, that talked about it. There's no set number of I option slots. It's how many people can we absorb in. Now there's some formulas that they've used to build this. The formulas will probably by default limit, so it's not open to just everybody that wants to sign up. But the idea is that anybody that is eligible for a B3 service today would be eligible for an I option doing exactly the same thing, and you don't have to worry about those funds running out sometime in the near future.
Let me stop for a second. Stephanie, did you have your hand up? I want to make sure if you wanted to ask a question. Otherwise, I'm going to keep going.
Keep going.
Okay. Let's see. Alicia says many physicians are not accepting new Medicaid patients, and those that are often full are often full. How will that be addressed? How are we going to ensure quality care?
That's a great question. We don't know how that will be addressed. We don't know. You're right. Many physicians will put a cap on their Medicaid funded patients. What if no one lifted those caps and not enough doctors signed up with tailored plans, and there were no more doctors accepting Medicaid? I would, say to the state of North Carolina, what do we do then when you can't find a doctor, period? Not just you lose your favorite doctor, but you can't find a doctor now who will take Medicaid.
Yeah.
There will be large physician groups in more urban areas who are less likely to have those caps, but we don't want everybody in North Carolina having to travel to one of the urban areas just to get a doctor, which many folks have to do already, but you don't want to force that or replicate that. So I don't know. I don't know that the state has a plan for that. And I think they're concerned.
I think, and again, this came from this conversation yesterday, they acknowledge that the specialists that we use by and large in our world and this community of people, yeah, and I'm sure some of them are in those large provider groups, no question about it. There's certainly people at UNC, and there's people at Duke, there's people that are already in network and they've been brought in. That's great, and where we have them, marvelous. But we also know that a lot of these folks are specialists that have very small groups. They don't have a large provider network that they work for. They're not part of Novant or, any of the others. And so that gets more complicated in terms of putting that network together. And honestly, as of yesterday, the department asked us, what do you suggest? They don't have an answer completely. I think they're thinking about it, which is good, but we don't have an answer for that. That is one of those things, though, that we're very, very sensitive to and are pushing, because it doesn't work if you have a system that's supposed to serve people with IDD, but it can't serve people with IDD. That falls far short of what the expectation was. To answer your other question, how do we ensure quality care? First off, we make the system work for us, as in those of you on the call. It has to be responsive to us, not us responsive to the system. That's one thing. The second is making sure that the doctors and the providers and the medical groups that we need and that we are comfortable with are available to us. That's the second piece of this. And the third is making sure that, they've talked for a number of years about being outcome based, that as long as we're meeting those outcomes, then the quality of care should be there. The question that is still yet to be answered comfortably in our minds is, what do those outcomes look like? If all we're talking about is, is your cholesterol under control? Is your blood pressure under control? These are what are called HEDIS measures. If those measurements of physical health are the only thing we're looking at, my guess is that our quality of care is going to diminish significantly, because we are much more than just our blood pressure and our cholesterol levels and the other things that we're going to be measuring on that side. We have to look at the whole human being. Do I have a place to live? Am I interacting with people? The kinds of things that we've been asking for years. And to quantify that's a little more complicated, and it's a little more involved than just taking your blood pressure. But there are ways to do that, to be able to get to what are the needs and the wants and the desires of an individual, and how do we make those part of the outcomes. That's the work that's going on right now. And again, in full honesty, I'm not comfortable yet that those quality measures are in place. I am comfortable that there are a lot of loud voices, ours among them, pushing to make sure that those measurements are built into this system before it's completed. And that's one of the things that we will be pretty adamant about, and already are.
So Diane asks, how easy is it going to be to opt out of tailored plan and stay in Medicaid Direct, or at minimum one of the standard plans?
Diane, as far as I know, you cannot opt out of the tailored plan and move into Medicaid Direct, because essentially, what's happening is they're moving all of Medicaid into managed care. And managed care is broken into either standard plan or tailored plan, those two types of plans. Medicaid Direct is a pretty exclusive group that's kind of left over for us to figure out in the future. They are not moving into managed care yet. I think they will at some point, but not yet. It's foster children, it's CAP for children, CAP for disabled adults. A few other select groups are going to stay in that Medicaid Direct area. People who have dual eligibility of Medicaid and Medicare, both, will stay in that Medicaid Direct side for a little while. Eventually, I think the plan is to move all of Medicaid under managed care. So you can't opt out of the tailored plan to go into Medicaid Direct. That's kind of going backwards. You could opt out of the tailored plan and move into the standard plan. And if you did so, You would lose, if you have the innovations waiver, you would lose the waiver and waiver services.
And any standing that you had, if you were, if you can't undo that. Once you walk away from the waiver, you can't go back and you have to go back into the wait list and wait in line for another slot to open up.
They have said you could go into the standard plan and keep your spot on the wait list.
If you're on the wait list, correct.
Yeah.
But if
But
you
if
have
you-
the waiver services and you're receiving them and you say, you know what,
You
I
lost
gotta have
it.
my doctor, I can't,
Yeah.
I have to choose, I'll take my doctors over waiver services that I'm currently receiving, you would lose your spot receiving waiver services, and you would not be able to regain that spot if you changed your mind later on.
Mhm. And just as the LMEs now have the B3 services, the Taylor, and they will launch the I option services, those will only be available in the LMEs, which are to become the tailored plan providers, right? Those I option services are not going to be in the standard plan. So any of these community-based support services that people are now getting through the LME MCO system, if you move the standard plan, you lose those. Those are not available in the standard plans. The standard plan looks a lot more like health insurance that you might have through an employer. For instance, at the ARC, we use Blue Cross Blue Shield, and our employees have health insurance through Blue Cross. If we were Medicaid recipients, we'd have Healthy Blue in that instance. So they, Blue Cross doesn't have the innovations waiver. Neither does Healthy Blue, neither do the other standard plans. So all of those specialized services go away in standard plans.
Okay. Diane, I recognize that you dropped off and that was your question. So this is being recorded so that you can go back and find how we started that conversation. So Todd, and you may have just alluded to this, Elisa says, what services would somebody lose if they have IDD and they go over to standard plan just because they want to keep their doctor?
I had heard, I knew they would lose their innovation waiver in their spot. I was just wondering if they lost anything else, because
Yeah.
we've got people
Yeah.
consider.
Yep.
Thanks.
Yeah, they'll lose everything else.
Yeah. So Marie asks, I think I understand that B3 folks who want to use 1915I services need an independent assessment done by a care manager. How does this happen for dually eligible folks in Medicaid Direct who will not have a care manager?
So a lot of folks in Medicaid Direct will be eligible for care management. And I cannot articulate for you how they determine that. I don't think anyone can, except maybe the state. But I would say, I'm going to venture out here and say, I believe most people in Medicaid Direct will be eligible for care management, and they can do that independent assessment for the I option services.
All right. I seem to be caught up on questions. Does anybody here want to raise their hand and ask something live that we may not have covered yet?
I don't know that this pertains to any of our folks with us today, but I will say we were really happy that the state just decided recently to move young little kids from 0 to 3 into the tailored plan, those who are born with a diagnosable disability. So if someone's born with an obvious intellectual or developmental disability, for instance, they can be eligible for a tailored plan from birth. We advocated for that because you all recognize the earlier the better, right? We get kids in their developmental years, we can do a lot more. If they sit on a wait list and wait for 10 or 15 years, we've lost those developmental years. So at this point, 0 to 3 could be in the tailored plan if they have an early diagnosis, and could be eligible for tailored care management, which would help coordinate those services.
Well, it's 5:05 and we allotted time. Go ahead. I'm sorry. I see you
Well,
trying to say something.
Yeah, I see Marie's made a good point here that I think I need to clarify. She said, oh, okay, I thought you had said Medicaid Direct would not be in managed care. You're right. So in the state, you're right. They're not in managed care yet. And yet the state has decided care management could be really good for that group too. And so they're going to stretch care management into that Medicaid Direct group, even though they're not technically in managed care in the same way that the folks with tailored plan would be. Good catch, Marie.
Mhm.
It's tricky, tricky.
Okay. Well, I don't, sorry, Kathy, I see your hand.
I wasn't able to type fast enough. So I asked the question about the private insurance and the PCP, but so my child's on the waiver. So I guess I'm hearing a contradiction or a conflict in that if if I don't choose a provider on the tailored plan, my child could lose the waiver, but my primary insurance is a private insurance.
Yeah,
And
let me,
comment
look,
before was that it would just be considered out of network.
Yeah, it would be considered out of network. And so,
I would not have to be required to choose a tailored plan provider.
no, nobody's required to choose a
Not a-
provider in network.
physical health provider.
Yeah, but the rates that Medicaid will cover are different in network versus out of network. And I believe the last I heard was out of network was, how much was it? Was it 90%, Lisa?
90%. Yeah.
So whatever they would have reimbursed your doctors and covered for you is 10% less than what it would have been if you were in network versus out of network. That being said, if you have insurance coverage from a different private insurance or you're dual eligible, now we're talking about a different funding stream that manages that. And so you're not having to give up your standard or your tailor plan or your waiver slot, but the billing and how that gets handled would be handled differently, obviously. And, if you're out of network, the rates go up, but if you've got another insurance company that's willing to pay that, then it doesn't make any difference. You still get to keep your doctors.
Okay, I've just been very concerned that because that I would have to, even though Medicaid is not the primary payer, that I would still have to, choose a provider I wasn't comfortable with or didn't know. Okay.
As a matter of fact, one of the things that we've been kicking around on the inside, we're not sure if this would even work, but for those small provider groups that are only going to get that are harder to sign up because of the complexities of all this, if they said, you know what, we'll just be out of network and we'll take a 10% cut, but for that 10%, I may have had to hire 2 or 3 people to manage the billing in the first place. They may actually be in a better place with a whole lot less headache. There's a lot of those questions, and we don't know if that would work or not. That's some of the questions that we're kicking around. So in network, out of network, you can get your doctors wherever you want. It's just how much money are they going to reimburse and what are they going to pay the doctors for the services you're getting, and how much would you have to come up with out of pocket?
All right.
It looks like Marie may have added a question here. Do we know if state-funded personal assistance is still ending Friday? Marie, are you referencing VIA?
I thought I work with Alliance and VIA, and I thought for both of them, personal assistance was supposed to end on 3/31.
I had heard that for VIA. I've not confirmed it. I had not heard that for Alliance, so I don't know. But that would be an LME by LME decision.
Okay.
That would be based on how they're handling their state funds.
Yeah.
I'm sorry, is that in reference to that question that just came through? Is that just for folks that are either already on the waiver or getting full Medicaid? I think my son gets B3 services right now.
That would be state-funded personal assistance only, Jennifer. So that's
Okay.
people who are not on the waiver.
Okay, thank you.
Mhm.
Great questions, everybody. We know it's so confusing.
Great questions. You guys are doing great keeping up with this stuff. You've done your homework.
Melinda, before you're done, would you put in the chat the link to the question bank? That if anybody has questions between now and the next one we do.
Sure.
So we can have those in advance. I mean, they may get answered, but we want to make sure that you have the ability in advance to get them to us. Because again, some of these questions that we're getting, especially the ones we don't know the answers to, we are turning them right back to the department and saying, here you go. You know, you tell us, and that gives us some from the horse's mouth. So we're not guessing on some of the things we have to guess, but this stuff, they'll either tell us or they won't, and then we'll know for sure, and we'll have a pretty good idea where we need to focus our efforts next.
Sure. There, as questions come up in your life or in your work, you can use that link right there. You can just cut and paste it into your browser, and we try to compile all those questions so that we can provide an answer to you and to everyone else with the same question.
We learn a lot from your questions, and as I think John was saying earlier, we've been listening to this stuff for 4 or 5 years and letting it sink in little by little, you know. So anyone new to this has got to be really just confounded with all of these twists and turns it takes to understand it. So don't hesitate to ask questions, even if they're very basic questions, because it's taken us a long time to understand it. And we want to try to help you if you have, if you have those needs.
And people that are in the business doing this, and I will include myself among them, there are moments where it's like, wait a minute, what? I didn't realize. And so this is a constant. If it were fixed and static and not changing at all, it'd be a whole lot easier, but it's not. And just about the time we think we have some things figured out, new things get added, things get adjusted, we move the start dates back. And you think, okay, moving the smart start date back is a simple thing, but it throws an awful lot of confusion and raises a whole lot of new questions. Well, what about if we had to do this, or what about that? What happens to the services that I'm currently getting? Do they extend? Do they not extend? It gets really complicated. And so there is no shame in saying, hey, I don't understand what the heck's going on, because there are moments on any given day where most of us don't understand. And that's where we have this team approach. And, you hear Melinda, you hear Lisa, you hear me, and there's several others that are on this call. This is a large group that goes far beyond just who you see and hear. This is a whole lot of folks kicking in and contributing to help us figure this out. Helen, did you have a question? Unmute yourself and go ahead and ask.
Yes, this is a very basic question, and it's probably going to show that I really don't know anything. What type of Medicaid do we have right now until the tailored plan starts? What type are we under?
You're under Medicaid Direct right now. And that is a fee-for-service type of funding, which means you receive a service and someone gets paid a fee for that service. So everybody now is under Medicaid Direct until October 1st, and some folks will move over into the tailored plan.
Okay, thank you very much.
Mm-hmm.
See, I was going to answer that question differently, and I think Lisa's answer is far better than mine. Mine was a little bit more in the weeds, because we have the innovations waiver, which is a Medicaid functions. It's a payment system for making sure that people get medical and physical and behavioral and habilitative supports across the board. Anytime a state wants to change how they provide that, they have to apply to an agency, a federal agency. It's the Centers for Medicaid and Medicare. It's abbreviated to CMS. It's a whole lot easier. So CMS administers this, and they have to approve the state wanting to change the plan. So they have this, what the federal government offers, the state makes a change, and there's a number of different ways they can change it. In our case, the innovations waiver is the 1915 C waiver. That's what we put together. It's coupled with the 1915 B waiver. So we call it the 1915 BC waiver that provides a lot of what we've got. That's kind of where we are today. When we go to the tailored plans full on, and that starts December or October 1st of this year, when that happens, all of this will be dropped into what's called an 1115 waiver. Now I'm throwing a whole lot of numbers and it gets really confusing from there because now we have the 1915I option and we start throwing all these different numbers. All these are just sections of the federal code that says you can change it this way, you can change it that way. So at the end of the day, the intent of what the Department of Health and Human Services in North Carolina is doing is making sure that the services that you've got don't go away, that the doctors you've got don't go away, and that you're able to access not only what you need, but there's more ability to apply and to give that to more people so that there's less people on wait lists. That's the intent. But without our very specific and direct input, it's easy for that to go off in a different direction. And so that's where what we're talking about today is so helpful, not just to us, but to the state to be able to regulate and adjust what they're doing so that it's available to you. So like I said, you start throwing out all those numbers, it gets hard to keep track of them. I like Lisa's answer a whole lot better. It's easier to swallow and digest, and it's just as accurate. It's just a different aspect of what we do.
Other questions?
Okay. Well, this is being recorded and we will have it posted on our YouTube channel by tomorrow and then translated into Spanish within the next 2 weeks. It takes us a little bit to get that done. And we will send information very soon about our April webinar, but it is 5:15 and we'll end that here today. And thanks everybody for joining us.
Go to our YouTube channel, sign up for the subscribe channel button, hit that bell, whatever it is they always say on the YouTube channels. So when new stuff comes up, you have access to it. We appreciate everybody being here and we look forward to seeing you again next month.
Bye,
Bye-bye.
everybody.
Bye, thank you.